if Rebecca were to go for conventional podiatric care, she would likely receive an x-ray of her foot, which would measure the angulation between the first metatarsal and the second metatarsal to determine if that's beyond average or beyond normal. Once that angulation gets beyond 10 to 12%, then oftentimes people are recommended to have a portion of their metatarsal bone resected and the head of the metatarsal bone slid over. They would also likely recommend that Rebecca's arch be supported with a custom orthotic. And the reason for that is, as we'll discuss today, when the big toe goes out of its alignment, the arch does not function properly. In other words, when the big toe goes towards the second toe, as is the case with most conventional footwear, the joint just below the ankle, the subtalar joint, will undergo more flattening or more pronation. So a conventional recommendation would be x-ray, custom orthotic, and if this angulation were large and Rebecca were in constant pain, she would probably be offered a bunionectomy. And what a bunionectomy is what I just alluded to a moment ago. There is bone removal, there is joint realignment, and internal fixation placed. What's interesting, though, about that conventional approach and how it differs significantly from our approach is we educate our patients to understand that this angulation here that's occurring is not a growth of bone. If we were to look at an x-ray of Rebecca's foot, the x-ray from the top to the bottom, we would notice that instead of her growing bone on the inside of her foot, what has actually occurred is her first metatarsal bone has literally been forced away from the second metatarsal bone by her big toe. So many of our audience members are going to wonder, how in the world can your big toe dislocate your first metatarsal? How it does that is, early on in our life, everybody is born with the great toe in direct line with the first metatarsal, more in keeping with the way Rebecca's right foot is. Shortly after birth, though, the footwear that becomes available for all of us begins this process of crowding our toes, oftentimes painlessly, and this feature is called tapering of the toe box. So over the course of Rebecca's lifetime, she was an athlete most of her lifetime. She wore lots of shoes for various athletic events that held her big toe in this position. And when the big toe is held in this position, the extensor tendon to the top of the big toe, extensor hallucis longus, and the flexor tendon to the bottom of the toe, flexor hallucis longus, are now pulling on this angle, and consequently, if they're pulling back on this angle, the toe is going to go that way, and the metatarsal is going to go that way. So this is the reason why people will develop an increase in that first intermetatarsal angle, it's called. So the way that our approach differs significantly is we rarely take an x-ray of the patient right off the bat. We generally educate them that we're not likely to see anything other than a dislocated joint. And at that point, what we do is we go about a process of, most importantly, showing the client how all of their footwear leading up to their visit has been dislocating their big toe as well as their fifth toe. Preventive bunion work is to ensure that the patient has an opportunity to understand how their footwear created the problem. For her foot to function normally, we need a shoe or many shoes for her activities that are going to be literally shaped like a natural foot. What the client will understand is as their big toe goes back into a proper alignment, the flexor hallucis longus muscle to the bottom of the big toe will better lift up under a shelf of bone on the inside of the heel bone known as the sustentaculum tali. This little shelf of bone has a special groove for that flexor hallucis longus that comes out under and all the way to the end of the big toe. So as the client reapproximates their great toe, they also begin to understand how that great toe influences their arch. So for that person who is more interested in conservative preventive care, we get the footwear that's going to enable the change. We teach them a series of self-care. We have a bunion stretch that's located on the website where we encourage the client to understand that their adductor hallucis muscle, which attaches to the big toe and attaches to the little floating bone on the bottom of the big toe known as the fibular sesamoid. When that adductor muscle gets very tight, the abductor muscle here gets very long and weak, and it can no longer do its job to help Rebecca support her foot and straighten out her big toe. We may be able to see the abductor here as I push Rebecca's big toe into shoe position. If you notice under the skin here, you'll see a subtle bit of movement there. That is Rebecca's abductor hallucis. In an ideal world, that muscle would be strong and short and holding Rebecca's toe over here. And when it learns to do that, Rebecca will also notice a significant component of structural integrity in her arch. So here's where getting the big toe out not only reverses a bunion deformity, it's also intimately related to proper arch function. Something that limits the progression of bunion reversal is many times before somebody gets to us and gets the information about stretching out their adductor, proper footwear, and using a splinting device called correct toes, many of those folks have gone so many years in this direction that their adductor is so tight and contracted and short that when they use a splinting product, instead of the splinting product nicely moving the toe back where it belongs, the splinting product unfortunately ends up pulling the other toes up and over because the adductor is too tight. So that's one thing that you'll need to be aware of. The other slight contraindication is if the individual has developed a very large intermetatarsal angle before they come to see us, we may never completely close down that angle. We will be able to get greater flexibility in the direction of the big toe. So that's a good reason for people to try to address their bunion early on in their life so that they can have more success with preventive conservative care.
I love running. I love running. I love running. I love running.